thank you for coming. This is the second part in an ongoing presentation series by the physicians in the Orthopedic and Spine Institute, and I'm proud to present Dr. Cooperman this morning, who has been a physician here for over 23 years at the medical center. He's going to be talking about hip replacement and the different approaches to hip replacement. And it's worth noting that over the last 10 years, all of our patients who have come to the hospital up until Dr. Cooperman started doing anterior approach hip replacements were here for at least 3 days. Just last year he did an anterior hip replacement on a patient that spent 1 day in the hospital. And through the innovative techniques that he's doing and that he's teaching our staff in the OR and on the floor, we're seeing phenomenal outcomes both in patient length of stay and quality of life. So without further ado, Dr. Andrew Cooperman.
Thanks, Jeremy. Well, here's a picture of me, younger and more vital. This is a little bit of my biography, where I came from. I was born in Los Angeles, but did my undergraduate medical school here in San Diego. San Diego is where I feel like I grew up, and so this became my home. I spent 5 years briefly at the University of Michigan doing my orthopedic residency, and returned back to California as quickly as I could. This is just a little bit of talk about where I come from in terms of how I found orthopedic surgery and what I think about it. I was lucky enough during medical school in my beginning of my senior year to realize that it was going to be important to me to be having fun 20, 25 years down the road. And I was able to think back and over my experience in my rotations on the floor to realize that orthopedic surgery is where I had the most fun. So I did pick orthopedic surgery. It's a great profession because we do all the what I call the good operations, relieving pain, restoring function, getting people back to their lifestyles. And it's one of those things where we don't treat everybody with surgery, only those people that really truly need it and also really truly want it. So it's very rare for me to see a patient in my office and say, you have to have surgery. It's something that we can work together to get to that point if it's necessary. But very important in orthopedic surgery, probably more than any other surgical specialty, is the need for teamwork. We need nurses, we need physical therapists, we need patient involvement to get improvement. And if we don't have all of those things happening from the doctor on down to the patient, outcomes are just not as good. So it's a very teamwork-oriented field. So my world came into hip replacement in a little bit of a roundabout fashion. I'm subspecialty certified in sports medicine, which is an arthroscopic field, and I have a very great interest in hip arthroscopy. But when I came here and started saying that I was a sports medicine doctor, the patients that come into the office from this neighborhood were people that were in their 50s and 60s who thought they needed a sports medicine doctor for their knee pain or their hip pain and needed an arthroscopy, but in fact they needed joint replacement. So over the 23 years I've been here, I've done more and more joint replacements, and so now I do quite a few joint replacements, and my interest in hip arthroscopy took me kind of naturally into an interest in hip replacement. But the hip is a ball and socket joint. The socket on the pelvis, called the acetabulum. The femoral head is the ball attached to the thigh bone on the femur. I tell patients that the femoral head and the socket are lined by articular cartilage. It covers the ball and it lines the socket, and that should look like the end of a chicken leg bone, nice and smooth and white and shiny. And when that layer thins down or gets damaged, that's where arthritis is. As far as movement of the hip, there are very strong muscles that surround the hip girdle. This is a side view here. This is the gluteus maximus, or the large buttock muscle. The very important walking muscle here called the gluteus medius, which attaches to this upper end of the femur here called the greater trochanter. And all these very strong muscles have attachments to this thin band of, well, it's a thick band of tissue called the iliotibial band, which goes all the way down to the knee. And these are the important motors that make the hip function, that allow people to walk normally. And these structures are what the anterior approach strives to preserve. This is just a quick cutaway look at blood supply around the hip. It's a very rich blood supply, as you might expect. There's a lot of musculature, and these blood vessels go to the muscle, but they also go to the bone. And this blood supply to the bone is one of the main reasons in both anterior and posterior approaches to the hip that we see blood loss during and after these surgeries, because the bone does actively bleed. And I think from the clinical standpoint, this is where you guys see drops in hemoglobins or perhaps hypotension on the floor. But it's all because of these very large blood vessels that supply not only the soft tissues, but the bone as well. So these are the two views that are kind of to keep in mind when we start thinking about different ways to get at the hip joint. The hip joint can be approached from behind, or it can be approached from the front. There are stout capsular and ligamentous structures on both sides that really support the joint and make it stable. If just looking at the structures from the back and how it looks from the front, you can just get a sense that there's a different view. There's a different ligamentous structure, but there's also just a different view of the osteology, or the bones, that we as surgeons get used to looking at. We get used to looking at the hip from the back or the front, and it's very easy to get disoriented when you're looking not at two-dimensional structures like this, but at three-dimensional structures intraoperatively. And that's where we have some of the differences in coming into the joint from the front or the back, and we'll go a little bit more into that later. So hip replacement is an operation that removes the arthritic joint and replaces that arthritic joint with metal and plastic pieces, basically, in a simplistic way. The femoral head, the arthritic femoral head, is removed, and a metallic rod is placed into the thigh bone. It can be secured with cement. It can be secured with bone ingrowth. I think the majority of us today are using bone ingrowth to allow the prosthesis to fix into the femur. A small metallic ball or ceramic ball is placed onto that piece to make the new femoral component. On the socket side, we shape and ream that socket hemispherically so it can fit a hemispherical metallic component into that socket, and we snap a plastic liner into that metallic socket. The new hip joint is then that metal ball into that plastic socket. We can put those pieces in from the back, from the front, or even from the side. All of those ways work. The results are uniformly good with all of them. And of course, all surgeons have a preference as to which brand or make they prefer, but they all perform very well, particularly the metal on plastic components. This is in contrast to the hemiarthroplasty, which I think you'll hear more about in the hip fracture series coming up next by Dr. Casca. The hemiarthroplasty is simply replacement of the femoral head, almost always done for fracture of the femoral neck. In this situation, a large metallic ball is used to fit fully into the native acetabulum. Nothing is done to the socket side. And this can function very well for some of our more elderly population who doesn't need to go through a complete hip replacement after fracture. So hip replacements and knee replacement, both of them becoming a very common operation in the United States. We actually went over 300,000 total hip replacements done in the United States in 2010. So we're probably, I would guess 2013, we're probably pushing between 350,000, maybe to 370,000 in 2013. And this is happening because our population is aging. As our population ages and our boomers start hitting 65, 70, 75, there's going to be greater and greater demand for these reconstructive procedures for arthritic degeneration of the joints. It's a great operation. I think it's the one operation that really improves quality of life for people. I can't tell you the number of times I have patients tell me that they can't believe they waited so long to get it done. They wish they had done it sooner. It's done to get back a quality of life, relieving pain, getting people back to daily activities and function, and it's so reliable these days. We have 96 to 98% good to excellent results. Complication rates are low, and it's a very satisfying operation as a surgeon to do. I would imagine as a therapist and nurse, it's very satisfying to watch people get back and walk and tell you within a day that they can tell they feel different already. It's very gratifying. A little bit of the history. It's a long history. Surgeons had the idea very early on, even back in the 1800s, late 1800s, that if you could take the arthritis out and put something in, maybe the pain would be relieved. And everything from ivory to metal. Dr. Moore in the 40s, using the first metal implant, a large femoral head implant, tried to relieve pain and actually had some success with these devices, but longevity of the device was the problem. They just didn't last. So the big step was in early 1960s when Sir John Charnley, a British surgeon, developed the first low-friction arthroplasty. That was a metal head on a plastic socket. This is the first one was done in the early 60s. The approach was actually from the side, entering by cutting the bone of the greater trochanter at the top of the femur to expose the hip joint and coming in from the side into the hip. That's what Dr. Charnley used. And initially, that was the approach everybody used when they started doing hip replacements, because that's what the surgeon inventor of the hip replacement did with great success. And I will tell you, I haven't seen any lately, but in the beginning of my practice in the 90s, I would see occasionally, maybe one every other year, every 2 or 3 years, a patient who had an original Charnley implant placed in the 60s, still in and functioning at 35 years later. So it was great durability for some of the earliest non-technically advanced components. It worked. So the anterolateral approach was taught and used for most surgeons, but in the 60s and 70s, the posterior approach gained a lot of favor in the United States, and surgeons at learning centers started to teach the posterior approach to the residents. And just like anything else, if that's what you learn, that's what you keep doing. It was considered to be easier than the anterolateral approach. You didn't have to cut any bone away from the femur, so you didn't interfere with the gluteus medius muscle, which is the important walking muscle, and its attachment onto the greater trochanter. So it became the primary approach to the hip for joint replacement and fracture, and was that way up until the last 10 years or so. And so this is very popular, it's very familiar, and very comfortable for almost all of us who trained anywhere up until the last 5 or 10 years. And it's still being used. It's a very good approach. It's very utility and you can extend